Hello, everyone. Hello, AIDS United family. We'd like to thank you so much for joining us today. My name is Nina Giddens, and I currently serve as the founder of Neo Repro, an initiative that helps nonprofit and corporate clients reach new and diverse audiences, especially Black women. And today, as we are rounding out this year's Black History Month, I am so excited to present to you From the Yard for the Movement. This is a roundtable discussion that tackles the vital topic of sexual health and HIV prevention on college campuses, especially for Black women. And y'all, I must say, you are in for a treat because we have gathered three amazing Black women that I honestly would consider to be living Black history in this moment. They are impacting sexual health and changing narratives around HIV on their college campuses and in their respective communities. And so I would like to just take a little bit of time to introduce them. I'll just say their names and give them about 1 minute each to introduce themselves. So first we have Miss Amaria Hardrick. Next we have Dr. Dominique Gwynn. And last but certainly not least, we have Miss Patrice Lewis-Outley. So Amaria, why don't you go ahead and start us off introducing yourself?
I was muted. I was going to get the chatting, but I was muted. I had to catch myself. First, I just want to say I'm so happy and excited to be here with you all. I'm looking forward to the panel, the questions, the conversations that we will explore, but we'll get to that. Hello, everyone. My name is Amaria Hardwick. I'm a Black trans woman, pronouns she, her, and hers. I'm a public health advocate. I'm also an alumni from Harris-Stowe State University in St. Louis, Missouri. Currently serving as a caseworker at a supportive housing shelter in New York City. That's where I'm based. And I've been involved in public health, community organizations, and programming and development since I was probably about 19 years old back home in Detroit. That's just a little bit about me. We'll explore a little bit more throughout the conversation. So I'll pass it over to whoever wants it next.
Okay, Amaria, thank you. And like you, I am really honored to have the opportunity to be here today and have this conversation. My name is Dominique Gwynn. I am faculty at Texas Southern University in the College of Education, Department of Health, Kines and Sports Studies, also co-director of TSU SHAPE Initiative, grassroots organization on the campus of Texas Southern University, providing sexual and reproductive health services, education, resources. I have been working in public health my entire career, so 25 years, specifically HIV and STIs. Again, honored to be here and looking forward to the conversation.
Love it. And Patrice, go ahead, round us out with these introductions. Uh-oh. Patrice, I can't hear you. Can you give me one more mute and unmute?
What about now?
Perfect.
Having problems all day. But hello, everyone. I am happy to be here as well. My name is Patrice Lewis-Outley, and I am a family nurse practitioner, and I am currently practicing at the Grambling State University. I have been practicing here for the last 15 years, and I guess you could basically say all things student health. So I am happy to be here. This is a much needed conversation, and I look forward to what we're going to talk about today.
Thank you so much, ladies. Y'all, I was not lying when I said we had living Black history on this call, okay? We have a family nurse practitioner, we have a public health advocate, and we have a professor of human sexuality. That right there is Black history if I've ever seen it. So I want to go ahead and get into our first question, and I'll pose this to all you ladies. So thinking back to your first year on campus, teaching or attending your institution, what messages, spoken or unspoken, did you receive about sex, about relationships, and about sexual health? And then a follow-up to that is, what do you wish was made clearer to you from day one? And Amaria, why don't you go ahead and kick us off?
Yeah, absolutely. Oof, I'm getting old because my first year of college was a few years ago, y'all. So what I can remember stepping onto campus was that there was a sense of, when it came to sexual health, there was this approach of like, don't ask, don't tell. If you're not having a conversation about it, then it's no need to address it. And it was just the conversation wasn't had until someone was impacted by it. And also when conversations were brought up about sexual health, prevention, risk factors, it always had this accompanying presence of shame and fear. It wasn't something where we had the opportunity or the guidance to foster language that normalizes what sexual health can look like for us. Because when you think about a first year college student, 9 times out of 10, that individual is fresh out of high school, right? And it's a clean slate. You're exploring autonomy, you're exploring your identities, and you're relearning what consent looks like in every different avenue for yourself. So if those conversations aren't being had, then how do we turn that risk into reason? You see what I did there, Nina? And I think that what was missed was a very crucial opportunity to normalize, hey, you're an adult. You are going to engage in things and be a part of things that could be life-changing. And this is how, one, we want to support you, because that's what's important. 2, give you the language to be able to express the things that you're experiencing, and also set you up for success. So that's what I think, and that's only from my experience. I know, like regionally, when you step into place, because I didn't go to an HBCU in a rural area, so I can only imagine what other college students, incoming college students, were imagining when they got there, because you really don't have conversations about sexual health in rural areas. Like, that's something that's just that. Don't get me started on Catholic schools, but I will pass it over to the next panelist.
Well, Amaria, like you, I had the same experience. I stepped on the campus of TSU in 2011, and it was very much, we really weren't talking about it, and we certainly weren't talking openly about it. Yes, those services were provided, but honestly, kind of like, yeah, they're provided, but they don't really need to be doing that. And it was from that, my co-director at the Shape Initiative.
Hold up, Dr. Gwen. I think we lost you a little bit. Go ahead and unmute again, because I know you're dropping gems.
I'm so sorry. Where did you lose me?
Just go back a little bit to talking about them having services on campus, but they shouldn't be doing that.
Okay. So, and that was very much, kind of the conversation, the message. Again, Planned Parenthood came in 1 day a week, provided testing, and that was it. My colleague saw the need for additional services, and that's where TSI Shape Initiative was born. And what I can say now is that HIV, STI, it's part of our culture. It's part of leadership and not just a side initiative. And I think in 2011, it was just a side initiative.
Okay, so I'll piggyback on with Amaria and Dr. Gwen. I agree as well. When I first stepped on the campus here as well, I mean, it really wasn't no broad messaging. It was just kind of understood, an unspoken message that, safe sex, the general messaging, safe sex, no glove, no love, that type of thing. But there was no in-depth discussions with the students about sexual health, sex, and relationships. And I think it could have benefited the students to know the how, the what, the why, the where, the when. because, everybody does not step on this campus with the same level playing field. And I think, that messaging, if it's broad enough for us and it is detailed for each student, it will give them that critical thinking skills that they need, that will help with sexual relationships, will help them keep their sexual health where it needs to be, and also be able to engage in sex and not feel like it is a taboo to have sex or to even talk about sex.
I love that so much, ladies. I was taking notes as you all were talking, and some of these messages around what defining really what safe sex is. We all heard the slogan, no glove, no love, but beyond wearing a condom, what does safe sex look like? I also loved, Dr. Gwen, you talked about this, eliminating culture around shame. At the end of the day, we're adults, and adults are going to do what they're going to do. And so how do we empower the autonomy that you said, Amaria, so that way they can go into these normal life experiences informed and make informed decisions? So love that so much, ladies. And I'm going to pose another question. We kind of want to talk about consent, communication, and safety by design. So what does it look like when we center mental, physical, and financial safety when designing sexual health and HIV related services for Black women? And anyone can kind of touch on this question.
I think it's moving behind. Well, right now we're working with the tools that we have in our toolbox for a lot of these, but I think it's moving beyond like our biomedical prevention strategies. And when you're talking about mental, physical, financial safety, embedding things like trauma-informed care, making sure that the things that we do are culturally responsive. I'm seeing more mental health support groups, trainings. On our campus, we are actually including campus police so that they will know how to respond to things like sexual assault and all those. So I think that part of, this is removing all barriers to, removing all barriers.
I agree, Dr. Gwen. I think also that it's just a holistic approach when Black women are seeking services. I think to make them feel safe in all areas, we need to approach the whole woman. I mean, what is keeping them from seeking the services that they need financially? What is preventing them from seeking the services that they need mentally? So I think in those spaces, it looks like having, like you say, trauma-based services, counseling to speak to the mental aspects of what's going on, financial resources, because what needs are there? How can I afford the medications if I come seek services, but I can't get the medication? So just a holistic approach when it goes to taking care of those Black women and their needs.
And I'm so sorry, Amaria, and it's jumping on something that Patrice had said earlier, because everybody doesn't come in with insurance and, their parents' insurance or something like that. So it is so important to eliminate all the barriers to access for them.
Yeah, I just love both of you ladies' responses. And I definitely just want to echo, because I see like the premise of the answer in responding to Nina is about barriers and resources and really understanding where and how like race, gender, and sex places us on that scale of risk, and really understanding how one, especially women, Black trans women are at higher risk for these things, but also don't have the resources or sometimes even pure navigation to place themselves in a space of which they're not concerned about risk. They're more concerned about prioritizing their health. Because when you think about risk, it's just like, oh, well, I don't need to do this. But you really don't have the tools to address the risk that's happening within your life so you can feel more empowered within the decisions that you have. So if assessing really where we are on that scale of risk and having that understanding would prioritize our bodies and help eradicate those barriers that are present for us.
Yes, ladies, you all touched on it so perfectly. We understand that intersectionality affects Black women like no other. And that's why it's so important for us to think about all the different barriers that we experience when trying to access care. I love the fact that you all touched on insurance. I will never forget being a first year student at Xavier University of Louisiana. Go, Gold Rush. But I'll never forget being on that campus and for the first time having to navigate health insurance without my mother there. And then being afraid that if I sought out services, my mother saw it, what that meant for my conversations back at home. And these are things that we're not always thinking about, but need to be talked about and addressed. So I love that so much. Now I want to get into some individual questions with you all. So Maria, I'm going to start with you if you don't mind. But you've spoken about how conversations around sexual health can feel intimidating, how they can feel secretive, have even a little bit of shame filled in them, especially for young women. What does an effective and affirming sexual health conversation actually look like in practice?
Thank you, Nina. Great question. Let's just rip the Band-Aid off. When you're having conversation about sex, it's human first. That's how we have to address and approach these types of conversations. And then when we have a conversation about the birds and the bees, as they say, because that's what I heard when I grew up, we don't want to make it feel like a clinical conversation or a disciplinary conversation. I know when I first started talking about becoming sexually active with my parent, and then also growing to have conversations with people in college, it was you shouldn't do this, you shouldn't do that, but there was no reasoning to that. There was also never really a conversation about boundaries, about what we actually like, what's okay to explore, really killing the cat that wanted the curiosity. Like, I can't be curious because everyone's, as I'm sure you all heard before, we're yucking someone's yum and invalidating someone's experience. So the moment that we address and approach a conversation as a human first, allowing curiosity, allowing those questions that are not wrong. Let's make that clear. When you have a conversation about your body and what you want sexually, it is not a one size fits all model. If that was the case, we would not be having this conversation right now. The moment that we welcome and allow people to explore and use the autonomy that's rightfully so theirs, that's when it can become to a state of feeling affirmed, of really understanding what you like, really establishing boundaries sexually, really understanding what consent looks like, really understanding who your partner is, really being able to identify if this is something that's healthy for you, because we're talking about sexual health, but with sexual health comes emotional health, because those two things intertwine viciously together. So the moment that we normalize it and not generalize it and slap a one size fits all model like Patrice or Patricia? Patrice. Like she said, we can't generalize these things, because the moment that we do, what are we doing? How are we going to have some fun? How am I going to get to know myself? So to answer your question.
Amaria, I love the way you started that off. That was a bar when you said human first. That right there, I think I got chills when you said that. It is human. All this is human, therefore there should be no shame around it. So Dr. Gwen, I want to ask you a question as well, because I think you talk so perfectly about the importance of trusted messengers and using them in your community to help with this movement of HIV awareness and prevention for Black women. So TSU Shape grew from grassroots gaps in care. What lessons can other institutions learn from taking initiative to present education around sexual health during freshman orientation? And does that look like PrEP awareness? Does that look like peer interventions? What does this look like on the different campuses?
Nina, it looks like all those things. And you're right, trusted messengers. I'm a 55-year-old Black woman, so the time when I was relevant, Black woman of childbearing age was a long time ago. So I can't speak for our students or young Black women. We frequently do listening sessions, asking them, what are the issues? What are the barriers? What do you need? And what we heard or what we would hear is that, the campus resources, the information that we brought to them, they wish they got it earlier. And so we looked and we thought, okay, we need to be hitting freshman seminar, which are the classes that they have as a freshman, or even better than that, freshman orientation. We have about 2,000 new students that come in yearly. Well, every fall. So what we did, we started working with our community partners, CBOs, ASOs. We have representation, again, from CBOs, ASOs, city and county health department. Our staff is small. We are 5-6 people, and that's, 2 students included. But we bring in our staff, volunteers, we split up, and we take the orientation sessions, I think they're like 75 to 100 students, and we break up over making sure that we do provide, STI education, information on campus resources, community resources, mental health, substance use, all of that.
I love to hear that you are getting these students right when they get on campus, freshman orientation, getting their freshman seminar, because I think there's something so special about leveling the playing field. We kind of touched on this earlier, but everybody comes into college with different definitions when it comes to sexual health terms, consent, communication, pleasure. All these things have different definitions, but I love the fact that you all are coming to them when they first get there and leveling that playing field. Now, Patrice, I have to ask you, many students, including myself when I was in college, relied on family insurance. And the fear of having their privacy taken away from them was a barrier for care for a lot of students. What barriers around privacy and insurance do you see most often? And how can campuses better protect students navigating care discreetly?
Some of the barriers that I see are that students are actually not getting the services that they need or getting the care that they need because, like you say, their attention to their
Patrice, I know you're dropping gems. Can you mute and unmute one more time? We're not gonna let this computer hate on us, okay? We gonna make sure these gems get to our audience. Let's try it again. A little bit, still a little far. You can maybe speak up a little bit. I know you're probably somewhere.
One more time.
Yes. Oh, that was it.
Okay, what about now?
Yes.
All right.
Drop those gems, Patrice.
Great question, Nina. So they definitely need to hear me talking on this one. But some of the barriers that we, often come up against are that the students don't actually want to get those services. They don't want to get the treatment. They don't want to get the testing because my information now is attached to my parents. And it could be relayed to the parents through explanation of benefits, or things that were set up by parents when the child was a minor. I know I set up, with my kids, Walgreens will notify me if a prescription is ready or Some lab has come through my email that, oh, we got new lab work. So students are reluctant to have that attached to their parents' insurance because I don't want my parents to necessarily know what's going on with me right now. So those are some of the barriers that we see that, they don't utilize the services because they are afraid that information that would get out. So I think some of the ways as student health centers we can help those students are to provide low cost services or, sliding scale services that the students won't actually have to utilize their parents' insurance, but they can utilize their work study pay to have a pay per fee service, I guess you could say model, to afford those services that they would necessarily not be able to afford if they had to pay for it out of pocket. I would say also ways that we can help students is look for funding, grants. There's a lot of grant and funding money out there that is catered just to help students or individuals who are uninsured or underinsured. So I think that's one of the ways that we can help. And those are a lot of the barriers that we see right now.
Thank you so much for touching on that, Patrice. Getting grants. I love that idea of like having them be able to use their work study, just different sources of funding in ways that they can get this care that they so desperately need, that we so desperately need as college students. Now, Dr. Gwen, I do have another question for you I wanted to ask. So, you are a professor of human sexuality. You approach sexual health from a status neutral and sex positive lens. Now, tell us, why is that framework so important, especially for Black students, and how can it shift engagements around HIV prevention?
Thank you. Both of them are super important, and especially for African American students, marginalized minority students. Now, status neutral framework is something that came out of New York Department of Health, Dr. Ani Blackstock, many years ago. And basically what it addressed was, status neutral providing service regardless of if that test result is positive or negative. The reason why, say pre-prep, if you had a positive result, of course, we are ensuring that you're connected to services. But with a negative test result, we gave you condoms and told you to come back the next time you wanted testing. So it's, again, stepping in and providing the resources, the services for those who are negative to remain negative, and those that are positive to go on to services. U equal U. And with sex positive, Amaria, I'm going to, sex positive is a non-judgmental approach. Like Amaria said, don't yuck somebody's young. And with sex positive, we teach you, no matter what your preference is, your behaviors, nobody's yucking your young. We're not hating on you for that matter, but we're teaching you how to be healthy, how to protect yourself. And I think that, both of these frameworks, sex positive as well as status neutral, they reduce stigma, encourage testing, normalize sexual health conversations, just a few things. And so those are kind of why we approach things the way we approach them at Texas Southern.
I love that. And Dr. Gwen, just to kind of level set here, you mentioned U equals U. So for some of the audience members that don't know what that means, can you just give them some insight, please?
Forgive me, U equal U. Undetectable is untransmittable. So for someone living with HIV, making sure that, of course, connected to services, if you are bringing your viral load down to non-detectable, because when we have that viral load at non-detectable, you cannot transmit the virus to someone. So that is our goal for anyone living with HIV, is to get your viral load down to undetectable. Now, do you need me to go into what viral load is? Viral load, amount of HIV in you, about viral load, amount of HIV in your body. Normal person, and oh boy, now really going to teach here, but
Love it.
Go ahead.
Yes, we love it. This is what you're here for, Professor.
So we know that when someone contracts HIV, it attacks your white blood cells. Now, your normal, and Patrice gonna help me here, normal white blood cell count for someone, say 1200 higher. HIV attacks those white blood cells. Now, what the difference in HIV and AIDS, when your T cell count falls below 200, we say that is no longer HIV, that is an AIDS diagnosis. So that viral load is that, not T cell count, but it is the amount of HIV in your body. And your medication brings your viral load down to the point of undetectable, ideally.
Dr. Quinn,
Yes.
I actually have a question because there's this myth that goes around,
Okay.
and when I hear people having conversations about being diagnosed with HIV, they think that you could either be diagnosed with HIV or you could be diagnosed with AIDS. So, why do you think there's this confusion and this because it labels AIDS as something as death, right?
Yes.
And nobody really understands how a diagnosis actually works and what could be the cause of that. So for example, someone who's diagnosed with HIV, what could it look like for someone further into their diagnosis to be diagnosed? Like, what could be the cause of that to be diagnosed with AIDS? And how does that culture shift within that diagnosis?
Okay. And Amari, I can tell you where the confusion falls in. And let me share that before I was a professor at TSU, I came to TSU again in 2011. But my whole career has been around HIV and sexual health. I started out at the health department as a disease intervention specialist. So when someone tests positive for any of the reportable STDs, HIV, syphilis, gonorrhea, chlamydia, and we can talk later about why they're reportable. But it's reported, if you test positive at doctor's office, health clinic, laboratory, those results are reported to the health department. Now, and I told you kind of a little background on why, but back to what you were saying, Amaria. So when you are diagnosed, run different tests to see what your viral load is. Now, and looking at your T cell count as well. If your T cell count is below 200 and that is accompanied by 2 opportunistic infections, and by opportunistic infections, it's a whole range of things that they can be, but 2 of those, that signals an AIDS diagnosis. Amaria, where the confusion comes in, once you are diagnosed with AIDS, there is no coming back. So, and I've had patients that came in with a T cell count of 2. Just that low, all right? But get on the medications, everything, maybe 6 months, a year later, their white blood cell count is 400, 500. Once you have that AIDS diagnosis, that is it. Now, HIV diagnosis, completely different. You can be HIV positive for 30 years. But what's most important to know about that, you can walk into services, we say bottomed out with a very, very low T cell count. And medication it's called Lazarus effect, bring you back up. But that confusion comes in is after that AIDS diagnosis, it is that. Even when your T cell count rises, it's, you can't say, oh no, I'm no longer, I have HIV. That AIDS diagnosis is, and I think that's very stigmatizing, but that's where that comes in, Amari.
Thank you.
I love that whole exchange so much because Dr. Gwen, I appreciate you for touching on like the medical scientific side of HIV as well as, the cultural side of it, I think it's so important to have education, because education is going to be the solution to stigma, I believe. And so I really appreciate you level setting for our audience. Sometimes we get in these spaces, we talk a lot about terms that we may be familiar with, but not everyone is. So I really appreciate you for breaking that down. And also, Amaria, for helping to open up the conversation of dispelling that myth of AIDS versus HIV and understanding both of those experiences. So thank you so much, ladies, for that whole interaction. Gave me chills. I love that. And Amaria, I've got a question for you. So at Harris Stowe State University, funding has shifted. And we've seen these funding shifts change what services and conversations are possible. So how do state funding decisions and regional attitudes directly shape students' access to HIV testing, their education, and their care?
Yeah, I think that this is a beautiful question. Sorry, y'all. And I'm so glad that we're at this point in this conversation, because I'm going to light it up. But first, go Hornets. However, so let's think about funding. Let's think of the power that comes with funding, especially in institutions. With funding comes visibility. With funding becomes making things essential, making things important. When funding is cut, like I experienced at my HBCU as an undergraduate student, in something like HIV testing, HIV literature, testing buses, giving people the liberty, and organizations like Greek organizations to have like those testing buses during their events come out and test people for HIV specifically. When that funding gets cut, that is not essential, and it's labeled as non-essential. That's how it just turns into something that we don't discuss. Furthermore, it turns into this institutionalized stigma. We don't have any knowledge on the things that are impacting us and that we're at high risk for, because more than half of us up in here is engaging in some high risk pleasure. So when you take the funding out, like I experienced, it really put the responsibility on the students like myself to ensure that these conversations are being had, and also these services are being conveyed. For an example, I had a very unconventional way of bringing HIV testing to the campus because I knew it would be hard. But I was just like, well, I was the president of the LGBTQ plus alliance there, and everybody's so fascinated with ballroom. For the audience that's watching, ballroom, think of Legendary on HBO Max, where they do a little cat canoe and dance and they vogue. I wanted to bring that because it's literally taking its way over in pop culture. And I was like, let me host a ball, because that is a community that I'm a part of. But within that presentation, let's talk about sexual health. I partnered with ballroom figures within the St. Louis community and had those people that were in the ballroom community. They were also community health workers. I'm like, hey, let's book your job. Let's book y'all to make sure that we have a safe place for people to test. Give them some literature. Give them, because we don't want to have the conversation where like, oh, your test was negative. It was non-reactive. We're fine. Take these condoms and go. No, I was very intentional within that moment, because I was like, we're not having these conversations. Make sure that when you guys are going through this assessment and actually testing them, we're measuring risk. We're having a conversation about risk. And so it puts the responsibility on the students. Also, another big thing and why funding cuts happen, especially in non-progressive areas, it's Missouri. It's a red state. It's not a swing state. That's a no-brainer. Regional politics shape the way that publicly funded HBCUs culture can exist. And if you have a senator or a House representative that's in that seat, and it's just like, oh, we don't care about HIV. We want to get immigrants out of our state. We're going to put all our money towards here, cut all of that. That's an issue, because then you have a higher number of newly infections. You have people who still run around with stigma, and you also allow an institution to be complicit in perpetuating stigma. So funding is really important in these conversations, and regional politics plays a really big part in that. We have to make sure that, like you said, Dr. Gwen, the moment that the freshmen are stepping in on campus, that you have someone that's encouraging them or giving them the tools to be someone like me, a peer, making sure that I'm conveying peer services, because it is something that is essential and it will not be erased, and our health is important. So
you said you was gonna fire off, and fire off you did, and we appreciate it. I must say, I love what you touched on about non-traditional partners when it comes to public health programming. I will never forget, y'all, I graduated my degree in public health, and I was not trying to attend a webinar about public health. It just was not the most effective programming that we saw. But I love the fact that you're like, we're going to partner with the ballroom scene in St. Louis, and we're going to get people the testing, the education, what that they need, and we're meeting them where they are. It really reminds me of I got to touch on my little college days. I will never forget in college, when I was doing a public health activation, my most successful one was actually a party during homecoming. And one of my best partners in the community were two party promoters. These are two 20-year-old guys. And we're at the party giving out condoms and talking about sexual health care. And I just think that is so important, especially right now while funding is shifting and it feels like we don't know where our money is coming from, really leaning into those non-traditional partners to ensure that people are still getting the services that they need. So I love that, Amari. I love that success story. And next time, please invite me to the ball. Thank you. I would love to be there.
Everybody's invited. Everybody's invited next time.
Yes. Next Black History Month. That's what we're going to have to do. Okay. There we go. Now, Patrice, I'm going to round out our individual questions with you. So many students assume that student health centers are only where they can go for sexual health care, especially, our students in more rural areas. Their colleges aren't located in big cities. They feel like those health centers are the only place they can receive care. But that stigma of receiving care in the same place that you study can be a little intimidating and keep these students away. So how does that misunderstanding affect follow through on testing and care? Wait, Patrice, one more time. I got to ask you to mute and unmute. I'm telling you, they're not going to prevent these gems from being dropped. Okay. We hear you a little bit. Try one more time.
What about now?
There we go. Just
okay. All right. So definitely there is a stigma attached. I would say the misunderstanding really causes a lot of students not to utilize those services. Basically, the short of it. They feel like if I'm seen there or coming in or going out, the only reason I came was for, treatment for an STI. And they feel like that is attached to them going in or coming out. And I think that causes students not to get the treatment that they need. It causes them to suffer with symptoms for longer than they should. It also causes them to spend unnecessary money by seeking services outside of the campuses when they don't have the insurance to go to those places. And I feel like when they do utilize those places outside of the health center, they don't get the cultural based care that they need. I don't feel like they are treated wholly. They may have just received symptom based treatment and still have to come to the student health center to get every aspect of what was going on with them treated. So I think it really causes a lot of issues with that misunderstanding and stigma being attached to health centers and only being here for sexual health care. Like I said, it just causes them to go untreated for far too long. And it's costly. It's costly.
Give me one second. Patrice, you kind of cut out a little bit at that end. You were talking about it being costly. If you could just repeat your last couple points for us, maybe mute and unmute before you do that.
Okay, can you hear me okay?
Yeah, just speak up for us.
Let me get closer. Okay, so I basically was just summing up my points that, like I said, it's costly and it causes students to kind of just deal with issues and symptoms for far too long than what they would have to, and not being able to receive that cultural based care that they actually need to get to the root of the problem.
Yes. Thank you so much for touching that. You know, when there is that stigma and we know that students know that this is somewhere that they can go to receive that culturally competent care, but they don't want to. And you're right, it does leave them with dealing with symptoms much longer than they should. And we can only imagine the long-term impact of dealing with symptoms and not seeking the care that we so desperately need. So thank you so much for touching on that. Now, ladies, we're wrapping up, but I just want to ask you all just a few more questions. So I'm curious to know, we kind of touched on this a little bit, but I want to hear from you all explicitly. What responsibility do colleges and universities have beyond compliance to actively support ending the HIV epidemic? And just give me like a quick little rapid fire. I think Dr. Gwen, if you want to go ahead and kick us off.
Yeah. Rapid fire. I say all the time, and y'all hear me say this, college campuses are cities within cities. Our residents are 18 to 24 years of age. It is our responsibility, and that addresses the EHE initiatives as well, to ensure that I think positive sexual health, that is part of their experience. Their well-being is our responsibility. Their health and well-being is tied to academic success. So it's all there together. So that, in my opinion, is why it is their responsibility, or it's our responsibility to ensure.
I just want to say this. Equity must be central to the campus's responsibility, okay? If we talk about missions, if we talk about the foundation, when these institutions were founded, it was about equity. It was about equality. It was about having equal opportunity. It was about ensuring that although with academic success, we're set up for life, for health, and also, here's my thing. I got to get comfortable a little bit with this too. I think it's an unwritten responsibility to make sure that the sexual health of someone who's paying rent to stay on campus is prioritized. I'm investing in this institution far beyond tuition. How are you investing in ensuring in my health, being here? Because I'm not just here to take a class. I'm growing. I'm evolving as an individual, as an adult, as a scholar. All of those identities come with that one journey of obtaining that degree, that certificate. So if I'm paying money, hey, we gonna make sure I'm good, okay?
Okay, hopefully you can hear me okay. Good. So I agree with both points Amari and Dr. Gwen made. I think our responsibility is, like you said, education. Point blank, period. Just education The students are here to receive education to go on to their careers, but we shouldn't have a tunnel vision on our education. We should educate on all life experiences so that our students are equipped to handle everything when they leave the university, and that includes sexual health.
I love that so much, ladies. I love that we talked about the health of the students is the university's responsibility. Once again, Ms. Public Health, got to say this part in here, the public health impact pyramid. It literally tells us what has the biggest impact on one's health decisions. And you all, one's individual choices actually has the smallest impact on their health outcomes. It's much broader things, their society, their community that impacts their health outcomes. So I love the fact, Dr. Gwen, you touched on that. Also, talking about equity being a part of our campus's responsibility. The whole point, the entire purpose of HBCUs was to ensure equity in education. So we should go back to that purpose in ensuring equity in health. And Patrice, you rounded us out so perfectly by saying we have to think more broadly about education. You know, these students aren't just here tunnel vision to get the degree. They are here to be educated on the world, to be educated on life, to be educated on their autonomy. And there are plenty of opportunities for the universities to do that, and they should take that role so seriously. Now, ladies, I have one final question. It's going to hurt me because I don't want this conversation to end, but we have to wrap it. So I want to ask you all, what's one change that could immediately improve how Black women experience sexual health in college spaces? Just give me one change to leave the audience with. Go ahead, Amari. Kick us off, girl.
Clean, clear, and simple. Prioritize the voices of Black women. And listen to what they say. Do not invalidate their experiences. Do not belittle what they're saying.
Can you hear me okay? More Black women providers who can relate to our student stories, who are culturally competent in care, just whatever those positions may be in those health centers. They see women who are there, are empathetic to their situations, who've experienced those situations, who are there and want to care for them. Clinicians, case managers, social workers, medical assistants, to the receptionists when they check in. Just those who look like me, who care about me, and who have the same experiences that I have.
Me, Amari, and Patrice is to write a grant. And I'm going to tell you why. We done come up with something. Got to hear us first. Providers that look like us. And my thing is, and something that Amari has said earlier, peer navigators. Young women on those campuses who have experienced, who are just like you, that can walk you through. Just like we have, and I say peer educators, peer navigators, but we have peer navigators at many of the CBOs, ASOs, health departments that walk you through your appointment process, all that. We need, I feel like on college campuses, we need, again, peer leaders, peer navigators, peer support to walk you through the journey with them, someone that you can trust. And then at the same time, you're modeling, you're teaching, you're educating, and they're going to pay it forward and be there for the next person.
I think you just summed that up so perfectly, Dr. Gwen. It's kind of like this old thing that my mom used to always say to me, like each one teach one, each one reach one. And the importance of having that peer-to-peer communication, that peer-to-peer support is so important. Now, ladies, we are rounding it out. Does anyone have any, last thing, anything pressing they just got to get off their chest before we wrap up this conversation? All right. And so I just want to give, before we officially close out, if each of you ladies could give a plug of where our audience can keep up with you, where they can find you. Like I said, y'all, I'm going to say it again. This is Living Black History. These are people you're going to want to keep up with. So if you each ladies could put your plug and where the audience can keep up with you.
Yeah, if anybody wants to follow me on Instagram, because I'm active there, I share content there. First and last name, Amaria Hardwick. LinkedIn, Amaria Hardwick, come connect with me. Let's party. And Facebook as well. I'm not very present on there, but I do share things. I do engage. Amaria, everything, all my socials are my first and last name.
Love it, love it.
For me, at TSI Shape on all social media platforms, Instagram. They say Facebook is for old people, so at that's what they say, Patrice. So at TSI Shape or Dominique Gwynn, Instagram PhD or TSI Shape. LinkedIn as well.
Yes, and if anyone would like to follow me, I am currently on Instagram. I'm on Facebook too, but I am also on Instagram, and it is Trice Shell, TRICECHELL on Instagram.
Perfect. And in case you all want to follow me as well, I am on Instagram at MSNINACARINA, Miss Nina Karina, and on LinkedIn with Nina Giddens. Ladies, I like to thank you all so much for this conversation. It has truly made my Black History Month. I have literally built my career on HIV awareness and centering Black women. So this conversation was everything that I needed and more. And I appreciate your vulnerability and for, your openness, your candor. We're talking about your own experiences. And we also just want to make sure that our audience keeps up with Melanated Movement. We would like to thank AIDS United and Melanated Movement for even bringing us here together on this day. And you can find them on all AIDS United platforms. And just a closing message to our audience. Ending the HIV epidemic, y'all, isn't just about medicine. We have talked about it today, the cultural impacts. So we talked about the public health impact pyramid, where it's not just about medicine. It's about movement. It's about access. It's about truth and care. It's about how we show up for each other on our campuses, on our HBCU campuses, and beyond. If you're listening today and wondering what your role is, here's the truth. We need you. Yes, you. We need you. Remain or become an advocate. Stay informed. Challenge stigma when you hear it. Share empowering, accurate information. And stay connected to the work. Make sure you visit the Melanated Movement Hub at AIDS United. That's AIDSUNITED.org to review resources, stay engaged with our ongoing content, learn how community-driven action can help us in the HIV epidemic. This movement is from the yard, and it only works for the movement when community remains active, informed, and committed. So once again, thank you to all of our panelists, our community who tuned in watching, and everyone who is committed to a future where Black women on campus are supported, protected, and empowered. Thank you all so much.